Assalamu alaikum. So the presentation today will be about acromegaly, and what we will do today, we'll go through the epidemiology of acromegaly, how to screen patients for a suspected acromegaly, the diagnosis, the complications, and the treatment. And we'll focus mainly on the treatment. So what I will do, I will take you through a case that I have seen in the clinic, and we'll talk about all these aspects and discuss them together. So the patient is a 43-year-old male who presented with headaches for 6 months. He had no visual disturbances. He has a past history of type 2 diabetes and hypertension for the past 3 years. He's not a smoker or alcohol consumer. He's married and father of 2 children. Blood pressure was 140/90. Thyroid exam was normal. Chest, heart, and abdomen were normal. Patient has coarse facial features, large nose, prognathism, large hands and feet. When the doctor examined for visual field defect, he actually had bitemporal hemianopia, although the patient did not complain of any symptoms. So clearly this patient has, not biochemical, but clinical evidence of acromegaly. So what is acromegaly? It's a rare disease, chronic disease characterized of growth hormone hypersecretion with a prevalence between 3 to 13 per 100,000 in European survey. The median age at diagnosis was 42, and the median delay in diagnosis was 10 years in females and 8 years in males. But what is interesting, just concentrate on this. So over the last 4 decades, the age of diagnosis of acromegaly has actually changed. So before 1990s, people were diagnosed with acromegaly at a young age, less than 40. And in this decade, people are diagnosed at an older age, around 45. The other thing which is interesting is that the delay in diagnosis. So before 1990, people will take like 20 years or more delay of clinical acromegaly before presenting to the physician, but now this has shortened to maybe 5 years. So why is that? Why people are being diagnosed earlier? Maybe because of better medical services, better awareness of physician, better awareness of patients. Patients now are more aware of changes that happens to them. So this can explain the shorter duration of presentation. So who diagnose acromegaly more frequently? So here the blue part is represent endocrinologists. So endocrinologists diagnose acromegaly more frequently, followed by general physician, primary care physician, and then internist. So these people are responsible for diagnosing or are more frequently diagnosing acromegaly. So what are the most frequent symptoms? The dysmorphic features are the most common symptoms that the patient will complain of. They also can complain of headache, fatigue, sweating, and sleep apnea. So when to screen for acromegaly? So when to screen, of course, any patient who present with clinical features is suggestive of acromegaly, you need to diagnose. The coarse facial features, the large extremities, you diagnose them. However, you also need to diagnose when a patient have a cluster of condition that is known to be associated with acromegaly. So the patient will have, for example, sleep apnea, uncontrolled diabetes, carpal tunnel syndrome, colon polyps, cardiac failure. All of these cluster of condition, even if they don't have the striking facial appearance, then also you need to screen these people for acromegaly. If a patient present with just prognathism, you may need to screen them. And of course, patient presenting with pituitary incidentalloma, you need to screen them for acromegaly. So how would you diagnose? You start with a very simple test, IGF-1. So IGF-1 is the single best screening test for acromegaly for many reasons. 1, it reflects the integrated growth hormone secretion. 2, it does not vary. The concentration is stable. It does not vary over the day. Does not vary according to the sleep or exercise or food intake, unlike the secretion of growth hormone. So growth hormone, as you know, is pulsatile, so we cannot rely on measurement of growth hormone to diagnose acromegaly. However, you need to interpret the result according to the patient's age. So you have to have the patient's value according to the age, and it's better to use the same IGF-1 assay to follow these patients. Now, you need to be aware that some condition may falsely lower IGF-1, so you may miss a patient with acromegaly, especially if it's mild. So malnutrition, hypothyroidism, and uncontrolled diabetes. Second is the dynamic test, or oral glucose tolerance test. And what we do is we measure growth hormone at baseline and 2 hours after administration of glucose. And failure to suppress growth hormone is diagnostic of acromegaly. We use this test also to look for remission after surgery. However, it's not useful to follow patients on medical therapy. Random growth hormone, don't measure random growth hormone for the diagnosis of acromegaly because of the things that I've told you, and because the level can overlap with normal people. Like normal people after exercise, if you measure their growth hormone, it can be elevated. So random growth hormone is not really useful. So what are the causes? Most common cause of acromegaly is growth hormone secreting adenoma, okay? So in the first column, sometimes it could be a co-secreting, so prolactin and growth hormone, like in 15 to 20% of cases. Sometimes a tumor could secrete multiple hormones, but this is rare. Now, ectopic growth hormone excess is rare, but it can happen with patients with pancreatic islet cell tumor. The other thing is iatrogenic. So people who are taking growth hormone for other reasons, not therapeutic, they can have features of acromegaly. And finally, growth hormone releasing hormone excess, it's very rare. It's like less than 1%. So once you diagnose acromegaly, you demonstrate the excess in growth hormone. The next step is you need to determine the source. As I said, most common cause is growth hormone secreting adenoma. So do pituitary MRI. And in the majority of patients will present with macroadenoma, between 70 to 77%. And the median tumor size is 15 millimeter. You need to know that the growth hormone level correlates with the tumor size. So the higher the growth hormone level, the bigger the adenoma. Now, what happens if you do suspect a patient's having acromegaly, you confirm it biochemically, you do MRI, and the MRI is negative, and this is rare, but what if this happens? It could represent two things. It could be pituitary microadenoma, not detected by MRI, or it could be an ectopic, and in this case, you need to screen your patient for other tumors in the abdomen or chest. So what are the complications of acromegaly? Mainly, you have to focus on mortality. Patients with acromegaly have twofold rise in mortality, and this is mainly because of cardiovascular morbidity, so hypertension, cardiomyopathy, and sleep apnea. Endocrine diabetes is very common in these patients, hypogonadism. Goiter is also a common presentation, osteoporosis and fracture, and other complications like arthropathy and colon polyps. So when you have a patient who presented to you with acromegaly, you diagnose your patient, you localize the adenoma, you need also to screen them for their complication from the beginning. So if they're already not non-hypertensive, you need to measure their blood pressure, you might need to do an ECG and echo, you need to do a sleep study, because even if they don't present with symptoms, around 70 to 80% of patients at diagnosis may have actually obstructive sleep apnea. So it's very important to document that. Of course, you need to screen them for diabetes. You check their other hormones. Do a thyroid ultrasound. If there is an abnormal neck exam, you may need to do BMD and colonoscopy to look for colon polyps. So let's go back to the case. So remember, this patient had features suggestive of acromegaly. So he had diabetes. His A1C was not bad, 6.7. Patient was on diet only. His IGF-1 level was high. You can see 122. The upper limit of normal is 44. The other hormones were normal, the prolactin normal, testosterone, and TFT. OGTT was done for confirmation, and it showed that growth hormone was not suppressed with glucose. So this is not the patient's MRI, but very similar. And you can see there is a pituitary macroadenoma. And the patient's actual size was 11 by 10. It was not invading the cavernous sinus. The cavernous sinus was clear, but it was touching the optic chiasm, and that's why our patient had bitemporal hemianopia. So when we talk about treatment of acromegaly, so treatment of acromegaly is surgical, medical, and radiotherapy. And of course, the main focus here will be about medical therapy, but you need to know all the options available. And what are the goals of treatment? Well, what you need to do is you need to normalize IGF-1 to normal. You need to reduce growth hormone level to less than 1 nanogram per ml, and I will tell you why in a minute. I will share a graph. Reduction in tumor size is another goal of treatment, reduction in mortality, and improvement in comorbidities associated with acromegaly. And why do we need to reduce IGF-1 to normal and reduce the growth hormone? Well, if you can see this graph, that it showed that biochemical control in acromegaly actually restores normal life expectancy. So the dashed line here, this is the life expectancy in normal population, or the survival curve. And people with different growth hormone level control have different mortality level. So if you have growth hormone in the first one, less than 1, then the survival of your acromegalic patient is similar to the general population. So if you have a growth hormone control, then you can have a survival rate similar to the general population. If the worse growth hormone level you have, the worst mortality. And this was also shown with IGF-1 level. If you have normal IGF-1 level, the upper curve, the patient will have a normal survival rate. If you have higher IGF-1 level more than normal, then you have a worst survival or increased mortality. So this is just a scheme showing you the management of acromegaly. So if you focus here, so the main treatment is transsphenoidal surgery. Okay, if you can get rid of the tumor, it's better. You can reduce growth hormone secretion immediately. You can take a biopsy or take the specimen, and you can even have a prognosis for your patient. If your patient goes into remission, that's great. You just need to monitor their IGF-1 level and maybe do an OGTT. If your patient has a persistent disease after surgery because the tumor was not resected, then you send the patient to medical therapy. However, you can, from the beginning, you can go for medical therapy in certain conditions that we'll talk about. So what are the indications for medical therapy in patients with acromegaly? The main indication is patients with persistent disease post-surgery. Now, there are studies that have shown that use of somatostatin receptor ligands prior to surgery can actually improve the remission rate. And this is true maybe in the short term, but not in the long term. And that's why the Endocrine Society does not recommend routine use of preoperative medical therapy to improve biochemical control after surgery. However, you may need to use it prior to surgery if you want to reduce surgical risk. So patients with severe pharyngeal thickness or sleep apnea or high cardiac output, getting a medical treatment for some times can improve these parameters and improve their surgical risk. Primary treatment is indicated in patients who are poor surgical candidate or if the tumor is not cured by surgery. So there is invasion, the cavernous sinus, difficult to take it out. So if we talk about medical treatment, it's very simple. You have medication that acts centrally, and you have medication that acts peripherally. So the centrally acting medication, they act immediately on the pituitary adenoma. And if you use these medication, you will reduce growth hormone secretion. And these are somatostatin receptor analog or dopamine agonist. Or you have a peripherally acting medication that acts on growth hormone receptors in the liver and decrease IGF-1 level. Okay, and this is growth hormone receptor antagonist. But the peripheral, just keep in mind that the peripherally acting medication will not affect growth hormone level. So the growth hormone level will remain elevated, but it will reduce IGF-1 and it will reduce all the features of acromegaly when you use this medication. So this is just to summarize it. So medical treatment, we have the somatostatin receptor ligands, we have octreotide and lanreotide. These are the old generation. And then we have pasireotide. Then we have dopamine agonist, again a centrally acting medication, which is cabergoline, and then the growth hormone receptor antagonist, piclazolone. So we'll start with the somatostatin receptor ligands. The old generation somatostatin, octreotide and lanreotide are the first line treatment. And when using this medication, you can control growth hormone and IGF-1 in around 50% of patients. You can also achieve reduction in tumor size. So you can achieve the goals that we have mentioned in treating patients with acromegaly. How about pasireotide? Pasireotide has a higher affinity to the somatostatin receptors and higher efficacy. Very effective medication, but there is a risk for hyperglycemia with the use of this medication, and you have to, of course, the cost and the availability. So it's a second-line medication. What are the factors that determine the success or the effectiveness of somatostatin receptor ligands? The smaller the tumor, the better response with the somatostatin receptor ligands. Again, the lower baseline growth hormone and IGF-1, again, better effectiveness. Hypointense tumors on T2 weighted images have better effectiveness, predictive of effectiveness of or a better response with the somatostatin receptor ligands. And if you have a patient who was treated surgically and you have a histology, densely granulated tumors have a better responsiveness, and this is because they have increased somatostatin expression in this tumor. So dopamine agonist is indicated as monotherapy in patients with mildly elevated IGF-1 and growth hormone. So you don't use it as a monotherapy in all the time, but it can be used as a combination therapy in patients who are not well controlled with one medication. Finally, growth hormone receptor antagonist, which is piclazolone. It is more effective than the previous medication. It can lead to normalization of IGF-1 in 65 to 70% of patients. It has favorable effect on glucose homeostasis. However, you need to monitor the liver functions test, and you need to measure to monitor the tumor size. So are you aware why do we need to measure the tumor size? Because the medication acts peripherally and does not act centrally. So the tumor will keep on secreting growth hormones, so there is a risk for growth hormone or tumor regrowth. But in many studies, the risk was not much, maybe 8%. Maybe in one study, it was a little bit higher. But you need to follow your patient with MRI. And finally, lipodystrophy may occur at injection site because of the effect of these medications on lipid. So this is a meta-analysis showing the efficacy of long-term use of piclazolone over the years. So in the dashed bar, patient, this is the IGF-1 level, the normal IGF-1 level at the start of the treatment, and the black bar is patient with high IGF-1. Now, over the years, you can see that patients taking piclazolone have achieved a normal response or normal IGF-1 level in around 60 to 70%, and they maintained their effectiveness over at least 5 to 6 years. So the clinical outcome for patient with a clinical outcome for medical therapy is one is reduction in mortality, which is extremely important, and this is because, as we said, with normalization of IGF-1 and reduction in growth hormone that you achieved with medical therapy. Improvement in comorbidities, okay, like improvement in left ventricular hypertrophy, hypertension, obstructive sleep apnea, better diabetes control except for pasireotide, and tumor shrinkage except for growth hormone antagonist piclazolone. So this is just to summarize the medical treatment algorithm in patients with acromegaly. So it looks complicated, but it's not. So the first line is somatostatin receptor analog, the old generation, so octreotide and lanreotide, okay? Now, if the patient, so just see, if the patient has a disease well controlled, which means an IGF-1 which is normal, you continue the same medication, and with follow-up, you may reduce the dose or increase the frequency of the somatostatin receptor analog. However, if the patient from the beginning did not have any response, which means the reduction of IGF-1 was less than 50%, then you stop the medication and go for pegvisomant, which is the growth hormone receptor antagonist. So this is the last. So no response, switch to pegvisomant, because probably the patient is having resistance to somatostatin receptor ligands. If the patient, however, is having partial response, which means the patient, the IGF-1 is reduced, but not to normal, okay? So you have two options. Either you increase the dose of somatostatin receptor ligands or increase the frequency, or you can add another medication. So here there is in partial response, you have the case for having to add a medication to start your treatment for your patient with acromegaly. So somatostatin receptor analog plus pegvisomant or plus dopamine, and you follow your patient and see which works. So how would you monitor patients on medical therapy? By measuring IGF-1. We said OGTT, of course, OGTT is not or growth hormone. We don't use it at all in patients with being treated with growth hormone receptor antagonists, because growth hormone will be already high. But even with other medication, the best monitoring modality will be IGF-1 level. And of course, you need to follow your patients with MRI to assess the tumor size. So let's go back to the case. The patient was started on octreotide LAR. IGF-1 level normalized within 6 months of starting therapy. His IGF-1 level remained normal, in the normal range during follow-up. Now, he's been on treatment for almost 8 years. Repeated MRI showed the shrinkage of the tumor size. Now he's having a microadenoma, so 8 by 8, and his metabolic parameters, blood pressure and diabetes, is well controlled. So what is the take-home message? Acromegaly is a rare disease, but increased awareness leads to earlier diagnosis and better outcome. Acromegaly is associated with increased mortality rate. Surgery remains the mainstay treatment, and medical treatment has very good outcome in normalizing IGF-1, reducing mortality rate, and shrinkage of the tumor size, except for pegvisomant. Thank you for your attention.